Okay, so I'm just going to talk about a little bit about the retinopathy of prematurity surgery. At this time, we have basically three approaches. The first one, scleral buckling, is very, very rarely performed, I must say now. Lens sparing vitrectomy is the commonest, and then the lensectomy vitrectomy. So I'm just going to talk a little bit about this. This is different from adult surgery. There are discrepancies in the anatomic and functional outcome. And bilateral sequential surgery is being preferred at this time in many good centers because I think these requires early surgery and the anesthetic risk is low. And if you take independently both eyes, separate eyes, I think they do fine. And we need to explain the risk benefit ratio to the patient and as well as obtain a good consent. Their expectations are very high. That is what is very important. We should be very realistic. And you need experienced neonatologist, anesthetist, special anesthetist for these ROP babies, because otherwise normal other anesthesiologists may feel very, very nervy. And the indications for the surgery are the stage 4A, 4B, and stage 5. And if there's a progressive progression despite UC laser treatment, and the dense vitreous hemorrhage, which might be there, or bilateral cases. I think lens sparing vitrectomy is something which is gaining more and more important. More people are doing for 4A, 4B, and the early LSV, especially if it's done in a progressive case after the laser, or even if anti-VEGFs are given, that gives the best results. I think you may get a case like this. This is our own case, referred from outside, lasered, very quickly went on to this. You can see this is very, very dangerous looking. We even thought of whether we should give anti-VEGF and just go in very next day, but we were scared of a crunch phenomena. We didn't do that. Otherwise, now why we do need anti-VEGF, I think vascularity, like in this case I showed you, can preclude the surgery. And anti-VEGF need judicious use. That is what is very, very important. We must understand that. But what here Parijal Chandra and his group has done, they have used per-op in very, very, that is, while doing surgery, they have put it, and it works very well in some of the aggressive looking eyes. Of course, lens sparing vitrectomy lead to 60 to 85% of reattachment. And this is a very good and number of studies, in fact, published from various places, especially also our country. And here we enter about 1.25 millimeter posterior to the limbus. We have to go mostly all the way a little more because you see lens is more globular, and because parasplana is not developed in less than 6 months, so that's the way. And you can have to also sometimes change location of the sclerotomies because of the proliferation which may be there, so you have to shift it. And the trochlear and other surgical instruments are to be angled. And the core vitrectomy, very nicely, which has been described earlier by Michael Tracy, that you do ridge to ridge, ridge to periphery, ridge to the lens, and central stroke, as well as optic disc to the ridge. If we follow this, we can remove, because here our aim is not to remove the hyaloid, which is very difficult, but sometimes limited removal of the posterior hyaloid is possible posteriorly. That is what is something which you can do. I think I just wanted to highlight this point to you. You must be very, very careful about this. If you have something like this, you are sure that this is regressing and it may be okay, you follow it up. But if you have something like this coming up all around, or even not all around, by maybe 160 degree or 180 degree or something, this is very dangerous. This may not be looking dangerous to you. No, this is very, very dangerous. This is the fibrovascular proliferation which has come up. And we had even published this and seen in this particular publication in 2013 that if you have a pre-existing or a new fibrovascular proliferation after laser, beware, they lead to unfavorable outcome. And that is what happened in this case. You see, other eye totally regressed. And this eye has almost formed, the whole retina has come into the center. So you can see how bad it is. Of course, this underwent surgery. I'm not showing you the surgery. And this could be done and attached back. And even this case, you see, ultimately, lens sparing vitrectomy, it could go back. I'm interested in this new procedure which we have described, nasal lens sparing vitrectomy. I'm happy that this has been accepted in retina, and maybe more people will do it. And this is something which we look forward to. Also, stop and slide technique, because these are longer instrument. So if you can do this particular technique also, you can save the retina from the full thickness, this thing. But our interest basically is all nasal approach, which is absolutely new, described by us. And this is something that you stick this infusion cannula in the center on the nasal side and make these endoilluminator and the vitreous cutter port on sides. I think this helps very well for 4B, where there is a whole temporal retina is coming up near the lens, because here you want to spare the lens. That's why this procedure works very well. Like, I think we have a little time. I'll show you if it comes up here. Yes, now you can see it here. In this particular case, you will see all the steps that basically you can go transconjunctival, but somehow many cases we do prefer making a little flap, because we want to suture it later. Sometimes if it leaks, there's a bleed because of the hypotony. So this is in the center infusion cannula. You can see right in the center infusion cannula has been put. And the biggest advantage is this nasal bridge itself supports it little bit. It doesn't touch the lens, which is usually a problem when we are putting it temporally. You have to somehow keep it angled up. And these are the two other ports. And this is the active port for your cutter, and you'll see that. And the other one is for endoillumination. So that's how you go from the sides. And the infusion here is coming from, and you can see it is fairly an advanced case of 4B. The whole retina is, and you can see even intraoperative OCT right over here. And now, first you do remove as much vitreous as possible. So you need to, that is what, and then you go to all these areas where you have proliferation and you can safely enter. That is the way you proceed, and you can achieve all the surgical objective very well when you are going with this all nasal approach, or a nasal lens sparing vitrectomy. So you can see here now, this vitreous is being removed, and after vitreous, this proliferation, which is quite vascular. I think this will need a little bit of a cauterization, and that is something which will be done here, because this is something which is a problem. At times it can bleed, and if it bleeds, then it's a problem. And after cautery, it will be just dissecting and separating this area, and you don't need to do more. You can leave it here, because if you tend to go more and you create a iatrogenic break, that will be end of the surgery. But you can already see on intraoperative OCT, now the retina has gone back, and it is start, and that is where you leave it now. And you can do a partial fluid air exchange and leave it, and you will see that bad retina, which was like a 4B, and here the ports were sutured, and that's it, end of the surgery. And you can see this retina goes back, and this is after 12 weeks. You can still see a little bit of a hemorrhage here, and you can achieve the surgical objectives very well with this procedure. This is at, you can see the magnified view of the same. So all nasal LSV, lens sparing vitrectomy, appear ideal for the 4B ROP with extensive temporal TRD. So I'm sure if more people do it, I think it is going to give to rewarding results. And this may be something case like this, which will need surgery with this kind of approach. And of course, stage 5, I'm not even talking. I think people are doing it. People should, but usually reattachment rate is only in 1/3 of the eyes. Functional results are poor, but even if we can give some ambulatory vision or perception of light, and so I think that may be much more matter to them. So in conclusion, lens sparing small gauge vitrectomy is the most important surgery for 4A, 4B. Early lens sparing vitrectomy is required at this time for 4A. Go early. If you go early, you have the best results. And lensectomy and vitrectomy is required for stage 5 and usually result in poor outcome, but should be done and tried in these desperate situations, especially bilateral cases. So thank you, friends. Here.